It's a pretty bad feeling when you get a young trauma patient in the operating room and it seems like you already start behind, you're losing the battle despite, the very quick transfer to the trauma center. As we dove into his injuries, we quickly realized the amount of injuries and the severity of injuries, as you said. So we're doing what we call damage control surgery. So just trying to control really all the profuse bleeding and control the contamination. Once we packed his abdomen, the chest temporarily, we moved into the interventional radiology suite for controlling that bleeding.
You have the anesthesiologist, you have the trauma team, you might even have some of the STICU team coming down to help out, depending on how sick they were. And Bryan was sick. He was bad off.
Basically, what we need to do is we need to look at where exactly the bleeding is coming from and if we can plug that immediately. It's not done by one person, it's a team. We have nurses, technologists.
And in his case, it was a pretty seamless case considering how seriously injured he was. But overall, as Dr. Prasad said, when they come in, sometimes their arteries can clamp down and you don't see an active bleed right away. But in his case, everything went very well.
He came to from the OR quite ill, and I just remember hearing about him and all of his injuries and just being shocked that we had made it this far.
I remember walking up and the head nurse, he walked up to me and he said, I just want to prepare you for what you're about to see. He said, this is probably going to be the lowest. There's going to be lows and there's going to be highs, and you can't get too low and you can't get too high.
In many cases like Bryan had, it's kind of being in the ICU, you take a step forward, you take two back. We knew he had the open abdomen. He did require another trip to the operating room, but they were able to quickly close his abdomen, but he still had many other injuries, broken ribs, orthopedic injuries. So it's very challenging. So it's quite a process, and there are good days and bad days.
The goals of the ICU team are to make sure the patient stays warm, make sure the blood pressure stays up. We basically played defense at that point and get him resuscitated to the point that he can go down to the OR again for another trip.
The name of the procedure that we do is called damage control surgery. And so you do, again, a minimum to recover the patient's physiology in the intensive care unit, and then try to optimize him as much as we can with the ICU team, and then bring him back in a matter of fact, finish the surgery that we initiated.
He absolutely was septic. After having undergone this surgery, he had a bacteria in his bloodstream, which is pretty common in the setting of having extensive abdominal injuries. Basically, you've got all these bacteria in your GI tract that are keeping up an ecosystem. And with that trauma, that bacteria leaks to places it's not meant to be. He did require antibiotics for quite some time to treat this infection.
And as a father, and knowing that he already had two children, we're thinking, what's going to happen? But the team of doctors and nurses were just incredible.
His survival was slim to none. It was rough, especially being home with the girls, but we knew it was going to be a roller coaster, and we knew that we didn't want to hope for too much and then be let down.